Good afternoon, everyone. It is now 2:03 p.m. Eastern in Southeast Michigan. Welcome from the Center for Middle East and North African Studies. I'm Muzammil Hussain, Assistant Professor of Communication and Media, where I study global media and communication and comparative digital politics at the University of Michigan. I'm also the Associate Director of the Center for Middle East and North African Studies. The study of Middle Eastern and North African region began at this university in 1889. Furthermore, the center was organized in 1961 and has been committed to area studies and language training across the Middle East and North Africa now for 60 years. Today, the center is also a designated comprehensive national resource center where CMENAS is dedicated to promoting a broader and deeper understanding of the region, supported by the U.S. Department of Education. And the center focuses on the histories, cultures, languages, and peoples across the Middle East and North Africa through the activities of promoting research, education, and public outreach programming. One of those important activities of public outreach programming that CMENAS does every year is the Fall CMENAS Colloquium. And today is our third of 7 scheduled Wednesdays this fall, constituting the CMENAS Fall Speakers Colloquium. Our current semester's colloquium is entitled Public Health and Pandemics Across the MENA, a Multidisciplinary Exhibition. Today's session considers gendered perspectives on this theme and is co-sponsored by the following University of Michigan units. The first is the LSA program on Arab and Muslim American Studies at the LSA Department of American Studies. And second, we also have the Center for History of Medicine at the University of Michigan's Medical School. Previously, and in the following remaining sessions of this fall's colloquium, we have and will look at the topic of public health and pandemics in the region through historical, institutional, lexical or linguistic, and also psychological, physiological, and behavioral perspectives with their respective invited guest experts and scholars speaking on those issues. Again, today's topic or thematic lens of thinking about public health and pandemics is through a perspective looking at the gendered perspective. So I'd like to welcome you all to today's session, where our guest expert has investigated deeply the topic of gender and health in the context of Saudi Arabia, one of the largest regions in the Middle East and North Africa, one of the largest nations in the Middle East and North Africa region by population, by GDP, by modernization, and all that goes along with it with regard to public health services, medical health infrastructure advancement in serving a rapidly growing and diverse population. Again, our programming runs on Wednesdays from 2 p.m. Eastern to 4 p.m. in this 2-hour format. First, we will hear from our guest speakers for anywhere between 20 to 40 minutes approximately. Then we will break for a period of public questions and answer period for about 30 minutes. And then we'll conclude with a slightly more intimate gathering of the students associated with this colloquium for a closed doors conversation with our guest to learn more about their profession, their research, and their academic research experiences. To introduce our guest, today we have Professor Ambreen Kazi Kamran, who is the Princess Nora Research Chair for Women's Health in the Department of Family and Community Medicine at the College of Medicine in King Saud University in Saudi Arabia. Dr. Kazi is also a family physician and a public health researcher. She has a special interest in mental health and social health of women. Professor Kazi will be speaking today on the topic of gender differences in approaches to pandemics in the MENA region. Please join me in welcoming Professor Ambreen Kazi Kamran. Thank you. Professor Kazi, the floor is yours.
Thank you, Dr. Muzammil. Good afternoon, everyone, and welcome to today's session on gender differences in approaches to pandemics in the MENA region. The gender broadly, gender is defined as attitudes and behavior of men and women according to the socio-cultural values and the physical environment. So today we are going to talk about these gender differences in context to economy, domestic violence, health, education, and technology. Although we know that the gender differences there may be various other areas which can be looked into. But basically, since in the context of pandemic, economy and the violence, health, and education has been very much has been looked into deeply. So that is why I kept these 4 areas to be discussed today. Now we know that the pandemic has a very pandemic means like it's global. So it has to have a very profound effect on both males and females. And whenever we are talking about mortality, the mortality is more in numbers for the males. But what difference is there? The effect on the social, the cultural, and the mental health is more, the effect is seen more in women as compared to the males. And this is where the gender differences are highlighted. So we are, and it has also been observed that it's not only that the effect is on the mental social health, the effect is also for a longer period of time as compared to on the males. So this makes it more important to see the differences for the males and the females. Another important thing is that there are, let us go to the next slide. Okay, first I will come to the economy. Now we know that economically, the pandemic has created a big decline in the economy world over. Around, when we are talking about the Arab region, then there is 1.7 million, and there is an estimate that 1.7 million people have lost their jobs. And amongst those, 0.7 are females. Even before the pandemic, the contribution by the female, the unemployment rate amongst the female was 18% as compared to the males, which is almost the double. So we can actually appreciate that when there are less females and even the low percentage of females in the labor market, which is around 21%, as compared to the males, which is 70%. So in that context, if 0.7 million lose their job, then it is a big effect on the females' economy. Now, the pandemic has affected all sectors of the economy, whether formal, whether informal. In the formal sector, if we are talking about, then the pandemic has affected health and education very profoundly. And we actually appreciate that a very big number of females is working in these both sectors, health and education. So the females are directly affected because of the pandemic. The rest of the areas, I'm not saying that the rest of the areas are not affected. They are, but the main direct effect has been seen on health and education. We also see that the informal sector, in which the females contribute about 62%. And amongst those 62%, there are domestic female workers, the vendors, the migrants, even the agriculture workers. So the females and these informal sectors, they have been either they have lost their income in form of losing the job, or they have been affected in form of increase in the working hours. For example, take the example of domestic female workers. The work has been increase in their working hours. There is limited or no access to health information and health services because there is no insurance coverage for them. So this all makes the pandemic, the economical effect more profound for the females. Now the next we see is the main concept of the unpaid work. Because many females have either given up their job or have turned to the part-timer jobs because of the domestic responsibilities. The look at doing the household chores and taking care of the elderly, taking care of the children. The school closures, the daycare center closures have pushed the women, have pushed the females to either reduce the working hours, and when they reduce the working hours, definitely the benefits are low, and the job security becomes less. It has been estimated that females are spending almost 5 times more in the unpaid work as compared to the males, and the whole responsibility actually is falling on the female, so depriving her from her own job as well as creating a more burden on her. So it's like a double burden. One is the burden of losing the job, and one is the burden of doing the household chores. And it has also been observed that only, especially we are talking in context to the MENA region, 1/10 of males only, they contribute towards the household chores. And that also has been observed in families where the education, the educational status is better and the economical status is better. So in those families, the males are found to contribute along with the females in the household chores. So this makes us appreciate that how much effect the loss in female economy is having its effect on the national level as well. Even before the pandemic, it was estimated that the income loss because of the gender gap is 27%, and now we can assume that it must be around somewhere 37%. It's just an estimate what I'm saying, but we haven't measured it in a very accurate way because there are many limitations. The actual data is not there, and still some work is going on. So let us see the future, whatever the future reports are going to tell us about it. Another major thing which is there in the Arab countries is that about the male-headed households and the female-headed households. So the policies of the government, especially, they are quite different when it comes to the head of the household. There are certain facilitations which are given to the male-headed households, although the range for the female-headed households is also from 2% to even to 26%. So there are some countries where there are 26% of the houses which are being headed by the females. But then also the facilitation which is given in context to the bank loans, in context to other facilitations for doing businesses is more for the males. And the pandemic has affected it more because even the past pandemic and the current pandemic, both have proved that the revival of the livelihood of females takes more longer as compared to that of the males. And this is because of the difference in the policies and difference in the facilitation for the males and the females. So with this, I conclude the economy part. And this was just, you can say, a snapshot of what has happened during the pandemic. Next, I will come to the domestic violence. This is another area, and you can say that it is an area which is close to my heart as well. And domestic violence, actually, as the word itself, it reflects the imbalance between the gender relationship, and it also manifests the power and the control which one member or one partner has over the other partner. Domestic violence, it varies. It includes physical, sexual, mental, and controlling behavior. For some of you, maybe the controlling behavior is not clear. Controlling behavior includes acts like the female is not allowed to visit a doctor without the permission of the male member. The female is not allowed to meet her family and friends without the permission of the male member. So the controlling behavior in the past 2 years during the pandemic, an increase in the number of cases and the number of calls both have increased profoundly. There is before the pandemic, the WHO study, which was conducted in various countries across the world, found that the MENA region has 30% prevalence of violence, any type of violence. And in the recent past years, the prevalence increased higher than this number, and specifically for one of the Arab countries, it increased to 40%. So the number and the domestic violence, actually what could be the reasons for the domestic violence? There are various theories. Some theories are that in the Arab culture, they say that it is accepted as a norm, and the females are pushed to accept the domestic violence in order to keep the family together. So it is accepted as something which is not a criminal act, and in some countries, even reporting an act of violence is not registered as a criminal act. Another important thing is that a female who suffers from domestic violence, she herself is stigmatized in the way that she is blamed for that violence, and the whole blame is upon the females, that you are the one you are the one who is responsible for this situation. So there is no reporting, and even the figures, which sometimes they go up to 65%. Even in those countries, still they are saying that it is underreported. The reason for another reason which has been targeted, and especially in context to the pandemic, and the social scientists are debating on this, is that because there is a culture, the males are more encouraged towards the outdoor meetings, and during the lockdowns, the males were pushed or they were restricted to stay inside their homes. Now this type of restriction caused and led to aggressive behavior, and that aggressive behavior has actually triggered the violence in various cases. Another reason is that because the males are considered as the financial heads of the family, and in cases where they have lost their job or there is a financial loss, then it actually challenges their position as head of the family. And again, it leads to the aggressive behavior, further leading to domestic violence. It's not necessary that each violence act is a physical act or a sexual act. It varies. There is another type of violence which is very much reported in the Arab world, is the blaming the female, blaming the wife for not fulfilling the responsibilities, for not doing the household chores, for not looking after the needs of the male spouse. So all that is also a very important type of violence. In addition to that, on top of that, another violence which has recently, not actually recently, but in the Arab culture, in the Arab countries, it has been recently reported, is the online violence and the digital stalking, which becomes more of concern for the female, because it can be made public, and it brings her, it affects her personality, and it affects her as a person in the public. So it has a very grave consequences and undesirable consequences, which sometimes end up in suicidal cases. There is unfortunate it was that despite of the increase in the number of calls and the increase in the reporting of cases, the restricted movement did not allow for the support organization to provide the comprehensive care. Comprehensive care means in context to the medical, legal, social, psychological care. which is provided to such victims was not available for the females. And also the online and the hotline support centers which are there, if the females were having no access to internet, then they were not able to access these support hotlines as well in order to get some sort of a help. The increase in the burden on the hospitals, shelter homes, and other social services also restricted the actual care which is supposed to be given to this victim, to these victims, was limited. And because the infectious diseases took up the whole priority, and not only in context to that the doctors were the social services were looking at or providing support to the health staff, but also the finances. The financial support which is given to such social services was also diverted towards the medical care for the infectious diseases. So in all context, the female on one side, there was an increase in the burden of in the frequency, in the intensity of the domestic violence, and on the other hand, a decrease in the support services. So again, it was a situation of dilemma, where it's very difficult to balance, Next, we come to the health. The females, again, have like they work as a frontline health workers, and the ratio of, especially in context to the profession of nurses, in one of the countries, in the one of the major countries in the Middle East, the ratio of male to female nurses is 1:9. The male nurse is only 1, and the female nurses are 9. So you can imagine the number of females who are working as nurses, midwives, other support staff, and because of their professional responsibilities, they are at a very high risk of getting the infection. And on the other hand, the same female has to look after her family as well, because she is responsible for the household responsibilities, the children's responsibilities. So to balance between the work and the family becomes a situation where a female needs to come under stress, and that emotional and physical stress can lead to low immunity, and again increasing the chance of getting the infection. So in context to health, it's not only that health as a female as a health worker, but also in context to her reproductive health needs. We know that females are a special gender who go through the reproductive cycle. There is pregnancies, deliveries, sexual infections, and other premenstrual syndrome, menopausal disease symptoms. So there are so many areas under the reproductive health where the female needs special care. And during the pandemic, all the services were targeting the infection. And these services, the reproductive health services, were being neglected. Even there was shortage and disruption in supplies. According to one estimate, 18 million females were pregnant at the time when the pandemic was announced. So all the focus or the priority which was supposed to be given to those cases, they were deprived of that priority and of that special care, which they were eligible to. Another context which we see under the health section is the lifestyle. Although the recent papers which have been done on the lifestyle and the mental health and even the nutritional habits during the pandemic in the MENA region, they haven't reported the difference in the males and the females. But even before the pandemic, MENA region was comprising the highest burden of chronic diseases because of the high rates of obesity and physical inactivity. Females, mostly they suffer from the overweight and the males from the obesity. And this pandemic actually increased that because there was an increase in the screen time, disturbed sleeping pattern, and a study conducted amongst the health workers found that even spending a lot of time on news which is related to the pandemic increased the anxiety and tension and irritability. So all these factors and the study, another study on lifestyle found that more than 50% are consuming unhealthy diet, the number of meals increased, the number of taking the vegetables and fruits decreased, and physical activity decreased a lot. Although there are home-based exercise programs and these type of facilities are available, but then also the pandemic has tremendously affected the lifestyle. And obesity, again, it leads to depression. Studies have found that obesity leads to depression and low self-esteem. The next sector which has been affected, which has seen a big difference between the males and females in context to pandemic is education and technology. Because of the household responsibilities, a significant number of female students, they dropped their education and did not even continue with the homeschooling. Because if the parents are affected because of the pandemic, or if any member of the family is affected because of the pandemic, then the female child is supposed to take care of the household chores and is supposed to help the mother rather than the male child. So again, the education of the female child has been affected at a great extent. The difference was also observed in context to the educational website which were introduced by the Ministry of Education. And it was found that those male-headed households, around 56% of those households had access to these educational websites as compared to the female-headed households. So it's not only the economy where the male and the female difference was coming, as when we are talking about the head of the household, it was also reflected under the educational policy, and the internet access was more for the male-headed households. And similarly, if the family has limited financial assets, a limited financial income, and if the affordability is for just one laptop, one computer, or one gadget which can access the information, then that preference was given to the male child of the family rather than the female. So a gender difference was observed there as well. Now, when a female is having no internet, then the info to access, because we know that how much we are depending on the internet technology for accessing the information for the pandemic, for accessing the information related to the prevention, related to the treatment. If there is no internet access, then the female again is limited towards these facilities. One study in one of the MENA region countries found out that 98% of the males were having access to internet as compared to 61% females. So this should be an eye-opener for everyone, and should actually make us think that how these gender, the gaps in the gender can be filled up by announcing policies which are equal for both the genders. There are certain recommendations. One recommendation is that disaggregated data should be compiled for both the sexes, that is the male and the female, and because that is going to drive the policies. That is going to drive the policies for the domestic violence, for education, for health, for reproductive services. The social sector, the sector which provides the social protection, the services should be improved in context that it was found that in one of the countries it is reported that 3 centers were closed because of lack in the financial support, and 70% of the staff was also reduced. So we need to have policies which are going to give support to such services. Counseling against domestic violence. It is important to have psychologists who are dedicated to provide counseling, and it may require that the family, both the members of the family and sometimes the extended family members should be taken into account when they are providing counseling. Because when we are talking about domestic violence, it not only includes their spouses, it sometimes includes the extended family members as well. May not be directly, their contribution or their influence is through the indirect way. Could be the mother-in-law, could be the father-in-law, or could be the other members. Internet access, essential information should be available to both genders. We see that in context to especially the migrants, which are from different countries, and they take up the jobs in the MENA region. These migrants are not familiar with the local language. So the information should be available in a language which is understood by them. And majority of those migrant workers are females. So there should be proper information available to them. They should have the insurance coverage. They should have the access to all type health services. The informal sector, as I said, the domestic workers or the vendors, which are mostly from the migrant countries or from the low socioeconomic background. So there should be a regularization of the informal sector so that the risk reduction is minimized. The informal sector should be given the similar benefits as the formal sector. There should be a coverage for the sick leave. There should be coverage for the access to the healthcare services for the informal sector. And the policies should be similar for whether it's the male or the female headed households, and the same facilitation should be given to the females to purchase the loans, to apply for the loans, and be able to start her business again in the same time frame as applies for the male. The inclusion of females as leaders, as decision makers should be there. The telemedicine and mobile health teams to provide the reproductive health services to females who are in the far-flung areas or where the health centers are not available or not accessible. And even in the lockdown period, it's not possible to access the health centers on need base. So it is important that the mobile health teams should have a record of the females who are either pregnant or near to delivery, and the services should be provided accordingly. The parents, one area which I did not touch upon while I was talking about the health is the sexual education, because we see that in the MENA region, talking about sexual education is not a favored topic, and you cannot go public and talk about sexual health. So you need to engage the parents, and as the children are not coming to the school and there is a limited information being delivered to them, and only access is through the internet sources, which in all cases they are not reliable sources. So the parents should be educated, and they should provide the essential sexual education to the children. Balancing the unpaid care, which is for which almost more than 90% of the time the female is responsible. There should be a balance in that, and the males should be encouraged to help, or equally, not even if they are not contributing equally, at least some percentage should be there to help the females in the unpaid care, that is the domestic care. And there should be a revised educational policy giving equal opportunities to both. Access to internet and the related skills should be there, because it has been seen that even if sometimes you have the access to internet, you do not know how to operate. And therefore it is important that the technological education should be provided to both, and the distant learning programs should be for the for all the hard to reach areas and hard to reach populations. So that is, I think, so a brief update on the influence of pandemic, on the impact of pandemic on both genders, and especially talking about the female gender. These are few of the references from which this presentation was based upon, and that's it.
Thank you so much, Professor Kazi. That was such an informative presentation. I know that we already have questions coming in from the public for the public Q&A portion. So I will facilitate with our first question and others that come in. I just want to say before we get into further discussion, I so appreciate what an impressive and informative, but also clear presentation. I mean, it's a rare treat to have an expert such as you come in, not only with your primary experience and your expertise in your area of work, but then also deliver such a comprehensive, nearly 360-degree angle and assessment of a complex event that continues to percolate into different sectors of society. Your four lenses that you've provided in your talk, assessing this pandemic's impact from an economic perspective, second, the domestic violence, third, health, and then a third, education and technology perspective, allow for us, I think, to have a more grounded conversation, even for those who are new to the region and new to the context. So thank you so much for such a helpful assessment and delivery of introductory remarks. I think we'll have a very productive discussion here. So first question comes from one of our class participants, Catherine Downs, who is one of our graduate students in public health program at the University of Michigan. Catherine, do you have a specific question? So Catherine writes, wow, such an enlightening data about the disproportionate number of female frontline health workers. Thank you for pointing to it. It seems like that facet of gender disparities in the pandemic has been neglected. So Professor Kazi, do you have any further reflection or comments about your observation that there's such a disproportionate number of women working as frontline health workers? Because I agree with Catherine's reflection as well. It's not, in hindsight, it seems so obvious, but it isn't something that the headlines, even in the West or other parts of the world, have reflected on this vital point.
Okay, thank you, Muzamil, and thank you, Catherine. Actually, the reason which I understand is that when you, the majority of the Arab countries, we know that if we go a little in the past, then the jobs done by the females were not supported that much. And it was the majority of the nurses which are working in the Arab countries, especially if you take the example of Saudi Arabia. So majority of the healthcare providers and especially the nursing staff is from countries which are which are outside Saudi Arabia, countries from in fact outside the region, and the Southeast Asia is contributing a lot in form of nurses and other healthcare providers, and even from the Philippines, India, Pakistan, all of these countries, they are sending their females to work as nurses in these countries. And the locals have gradually started coming. And then also the females being I think so, it starts from the Florence Nightingale. Remember the Florence Nightingale? She was the first woman to work as a nursing. Actually, at that time, nursing was, I don't think so, it was taken as a whole, as a big profession. So from those days, since the females tend to be more into caregiving and more understanding and more soft-hearted, so that could be one of the reasons that females are more into as compared to the males when we are talking about the nursing profession, especially. And the other reason is that maybe it's more comfortable to be with the females and to work with the females. Now, gradually, the government has started inducting the local population into the nursing colleges and the nursing programs, and training is being imparted, and to both the males and the females. So hopefully in future there will be a balance. There will be a balance, but it may take some years to reach that balance.
Thank you. So it seems like there's, I'm sure more than two, but at least two directions come to mind from your reflection on Catherine's prompt. On the one hand, obviously there is quite the observable inequity in women working on the front lines in the nursing occupations and other care positions like that. But in your talk, I also am reminded you noted that it's not just the question of why are so many women overrepresented, but what also does that put them at risk of? So you noted, I think, in your talk that when the pandemic happened, they were in a position where they were, number one, more likely to contract the virus, but then also to go home because they're also doing much of the domestic work, the domestic labor inside the household. They're also likely to be at risk of spreading the virus. So it seems like this issue requires a very robust and thoughtful redress for a number of risk factors, not only how it affects women, but those that women are also connected to in the household, in the patient care services. I'm so glad that we're having this presentation. Our second prompt is from Rachel Goldenberg, one of our undergraduate students at the University of Michigan. Rachel asks, are gender inequities more stark in rural or hard to reach areas in Saudi Arabia as opposed to the urban metro areas of Saudi Arabia?
Okay, now this is very interesting because according to my observation, I think so, rural women are better off. Although it's surprising. It's surprising because, and why they are better off? Because the structure, the tribal structure. Because in the rural areas, if there is one area which is occupied by one tribe, and so there are linkages in the tribe and the profession. Even I was surprised to hear that although the driving was not allowed in Saudi Arabia, say a few years back, but the rural women, they were actually driving tractors and big carts in their fields and when they were commuting from one house to some short distances. So they were driving. And it was surprising for me to know that on the other hand, the urban woman was not allowed to drive. So I think so that the disparity is not so much in the rural areas. I don't have a first-hand information, but what I have read and what I have observed, based on that, I think so it's more in the urban areas as compared to the rural areas.
Got it. That is a very interesting fact and observation. I'm not sure. I'm just thinking out loud. I'm curious how much rurality correlates with perhaps a decreased risk factor to COVID in other cases in other regions of the world. But that's you're certainly opening up a lot of testable hypotheses and questions to be looked at from this complex pandemic that has unfolded around the world. Yeah, I will keep an eye on the Q&A if there are more questions for Professor Kazi. As we do that, I'm happy to continue the dialogue here as well. Professor Kazi, as near the ending of your presentation, as I was listening, I was trying to identify, kind of a broad thesis or summative statement that I thought I was pulling out of your very informative presentation. And if I may, I was curious if I could share one and see what your thoughts were on it. So I think, combining all of the different angles and levels at which you've helped us understand the pandemics and its impact on women, and in reverse, in other areas such as internet access, domestic violence, elsewhere. I think one big takeaway that at least I'm taking is something like gender inequity is a risk factor for public health, especially during the pandemic. Gender inequity is itself a risk factor for the public's health, especially during the pandemic. Is that a fair assessment, or is that have I got that wrong, do you think?
No, I support you. I totally agree with you. And yes, this is the situation, because gender inequality was already there. It was already there. It has been there since a long time. And what pandemic did is to make the situation more aggravated. It aggravated the situation and aggravated these inequalities, and in fact brought these inequalities to a very to a level at which the social scientists have been pushed to study them in more detail, and at the same time recommend to the government that the policies and programs should be in place, because you know that the outbreaks have been taking place since the last maybe last 20 years. There has been the SARS, the Ebola, and the other type of coronavirus infections have been outbreaks, sometimes at a small extent, and sometimes at a larger extent. So it is very important that these gender differences should be taken into account. And yes, the pandemic has highlighted them at a higher level.
Mm-hmm. I suppose any testing of a system will show in which situations it may not be optimally structured or designed, and it may also show where the system can break down. From that perspective, I think there's such incredible value in the way that you've presented this material to us. I'm more of a sociologist. I think about social institutions and political institutions, and from that angle, the line of questioning typically focuses on what can we change in order to make a society or a nation and its relationships to the society more resilient for tests, economic tests, public health tests, things of that nature. So I think this going back one step to your previous reflection on finding that rural social institutions were a bit more robust, and it looks like the common factor there was that women had more agency in rural areas to drive and to assess their individual situations and to act on those individual situations, whereas in perhaps the urban areas, there are perhaps more formal institutions that structure women with less agency, and that has made the situation more perilous. It seems to me that this is one of the most empirically validated ways to think about why and with what benefit to increase gender equity and to decrease gender inequity around the world.
You are right. But on the same, if we talk in that context, then I think so. The recommendations have already been put in front of the government, and based on that, already the work has started. And the economical support, the domestic support, and the social support which is being given to the woman right now, I think so never in the past the situation was like that. And now if you look in the mainstream, the contribution by the females, you can take any sector. You can take any sector and you will find that females are contributing and they have the say. They are vocal. They are more vocal, and they are their rights are more protected, be it legal, be it social, educational, health-wise, any sector. So things are changing, but gradually, and it may take some time to be at par. But it is good to see them. It is good to see the things going in the right direction.
I see. Thank you. I mean, I think that's such a grounded way to think about it. From your response, I take it that there's a feeling, perhaps shared widely, that in the region and in Saudi, there has been a lot of social and institutional change, but it is being seen as progressive change, where people are feeling optimistic and energetic about the future. Is that, it's a hugely speculative question, but do you have a thought there?
I'm sorry, I may not have understood.
It's based on your reflection to the previous point. I get the feeling that there's a shared sentiment of optimism, that change is happening, but that the change is also good and in the right direction. It's a speculative question to ask you, but do you feel that is a general feeling in the areas that you serve and in the populations that you serve?
Very much, very much, very much. There is optimism. There is a lot of optimism. There is a lot of you can say. And one thing more I observed, which is that before the females used to complain that they do not get the opportunity, and they have to actually wait for some opportunity to come. And now they don't have to wait. Now they know that, okay, this is the opening, here is the opening, and this is where I want to go. So there is a lot of optimism, there is a lot of encouragement. There is a lot of encouragement, especially for the young because since I'm in Saudi Arabia, so for the young Saudi girls, there is a lot of encouragement, motivation, and avenues. Many avenues have opened up for the females. So, and I think so. In near future, you will find a big difference, and maybe after a few years, we may not talk about the gender differences or the gender inequalities. it may come to that much balance.
Wonderful. Andrew Williams, one of our master's students at the university, asks, what was the largest challenge to you when collecting data from women? And would that data, or could that data be skewed by age in participants? So if you could go into a little bit about what the realities of collecting data on gender and health issues are to you, and if and how that data is skewed by age or perhaps by other factors. I think the audience would be curious to learn about the methodological experience.
Okay, since now I belong to the public health field, so when you go here, there was one major obstacle which I faced when we were doing our one of our major research projects was related to women health only, and the major obstacle was that the collecting the data at household level, because at household levels I'm talking about a situation which was 8 to 9 years before. At that time, collecting household data was very difficult because of the security concerns. The people did not used to entertain any data collectors, and there was an apprehension that maybe it could be someone else, or maybe someone whom they are not willing to allow into their home. So one was security and one is privacy. So both of these obstacles were there. And so we had to collect our data from the primary healthcare centers, but after advertising it at the community level, meaning that putting the roll-ups inside the mosques, because the mosque is one of the place which is visited by the majority of the public, and then putting the roll-ups in the schools, other educational institutes, putting the roll-ups in the malls, shopping malls, and the big area shops, and all the big pharmacies. So that was the way we used to advertise the study, and then ask the community people to come to the primary healthcare centers, where we have the people from all the age groups, and from both the genders. But again, we faced the difficulty of the people who are working, the working population, missing out the working population. So we had to go to their workplace. We had especially had to get the permission and had to go to their workplace in order to gather the data from their workplace. So this was what was about 8 to 9 years back. But now, as I said, because of the situation was changing, but then the pandemic came. And we had to go. Now the data collection was through the online system, through the social media, and that was where we were using all type of networks and collecting the data through the networks. But I feel that now the concept of research has also grown a lot here, and the people know about what is public health research. So I feel that if I'm to do a study in near future, then the response which I will get from the community will be more encouraging what was there in the past. So I cannot be 100% sure about it, but it is a feeling which I do get whenever we are talking about public health research with the community people.
So it sounds to me, to summarize some of the most very important things you said there, that over the past decade, there's been a growing acceptance of the public health research and service enterprise across Saudi. And that growth has been built, it sounds like partially on the productive work of building relationships in different institutional areas at the mosque, at the marketplace or the shopping mall centers, with family leaders. And so just putting in a lot of time and cultivating productive relationships seems to have kind of increased the odds of enabling further public health research today. I find that very interesting, especially then you remarked that there's been a pivot with everything going online. You know, in your presentation, you observed that yeah, I think the amount of time spent on screens increased a lot overall, differentially between men and women because of differences in access, but still people spent a lot more time on screens. And I suppose that kind of provides a somewhat of a captive audience to solicit for research participation. How has that been? Can you speak a little bit more about, you know, what it's like to send surveys or to do participant observation in the COVID period, primarily through, I don't know if it was like on Zoom or on online surveys. Can you describe some of the work that you've done in this context?
The online surveys is like when there is a you want me to explain the response which we have got
as much as you'd like. I think the audience may appreciate getting kind of a small example of how you used to do a study in the community before the pandemic, and then how you had to change it because everyone was at home online, but not in the public. So how did a typical study in your research tradition, how did it change because of the pandemic in how you deliver the study?
Yes, it changed a lot, honestly. It changed a lot because when you are the face-to-face interviews, when you do them in the public, the first-hand information and the body language and the facial expression and everything is in front of you when you are doing in the community. But when you are sending out through the online the questionnaires, and so you don't know that if the participant has been has actually read the question, he has answered it properly, was he focusing on it, or was he doing simultaneously, was he doing, or he was doing something else. So definitely the information, according to my personal observation, the information which is gathered when we are doing the community surveys, it's more reliable as compared to the online surveys. Another is that you know that who is answering your question according to your exclusion and inclusion criteria. According to your inclusion criteria, you know the person who is standing in front of you, the age group, the gender. But when you are doing the online surveys, you are not sure about that whether your inclusion criteria is being fulfilled or not. You have to trust on you have to have the trust on the participant, although the number of participants is high, is way more in the online collection. It's way more, you easily get in thousands. But the quality, I think so, is more reliable when you are doing the community surveys. So that is a major difference which I feel is there. And besides that, I think so it's the understanding of the questionnaire itself. If the participant is in front of you, you can explain your question if something is not clear, especially in relation to the social sciences subjects. In relation to social sciences subjects, there are certain questions which need explanation. And if the participant is not clear, then he or she asks. But in the online surveys, that opportunity is not there. So these are the 2 or 3 major differences. I hope I have answered your question.
Very, very well. Thank you so much for expanding on that a bit more. I mean, we can continue having, I think, a further discussion. I do not see any more questions from the public at the moment, and I think we've spent our allotted time, in fact. So everyone, thank you for all of your questions, especially from the public here. This will conclude our time with Dr. Kazi.